objectives for this session is that while taking gingivitis seriously now is even more important than you believe. All right? Recognizing the importance of dental hygienists throughout gingival health is so important on the journey for patients and our consumers. Considering the benefits of supporting mechanical cleaning with appropriate consumer healthcare products such as stannous fluoride, something simple. Champion prevention and management of gingivitis. I'm also going to get some input from you, so this is not only a lunch and learn, this is interactive. So along those lines, I want to just take a second and say I'm thrilled that we have been invited to present to you today and present to a profession that I consider amazing because I'm part of it. I'm actually a hygienist too, as well as my two colleagues. So we love this. Thank you. Okay? So I know you're going to be wowed by not only what I have to say, just I'm patting myself on the back, but also what Lisa and Crystal has to say. But before we do that, I just want to go over a few things and share a few words. People and professionals in general consider dental hygienists as the healthy gingival champions. You love that line? I mean, we are. All right? And I couldn't agree more. Being in industry has a genuine desire to work with dental hygienists because we are the footprint to making sure that oral health in our nation and around the world can help reduce the burden of this horrible disease. And it is. Gingivitis, itis, is a disease. We want to obliterate it. So why are we so greatly positioned to be able to not only diagnose, and yes, I am using that word, okay? Oh my goodness, a bad word. And treat gingivitis, all right? Very simple. We have the dedication and the knowledge. We are trained, and we're ready to help. We are the healthy gum advocates. All right? We can and should raise the awareness for this opportunity. We will reignite passion. We have probably never lost the passion, but you know what? There's some people in our profession that might have kind of slipped through the cracks a little bit. So we all have to motivate them, and we have to motivate our patients. Encourage everyone to use materials that can help. We are best placed, and we are respected and more than willing, but we can't access everyone, at least not yet. We want to work with everyone. As an industry partner, as a hygienist, I want to make sure that our corporates are all ready to know that our role is so important. And how what we can do is help reduce this disease and mutually benefit through this relationship. We all have excellent communication skills, right? All right? We are well trained, and we have fine-tuned our soft skills to appropriately affect each individual we talk to. We have skills that require us to really reach out. And we need to reach out to our policymakers and all kinds of funding bodies to make sure that we can do a positive change. It all starts now. So knowing all of this, I just have a quick question, and we're going to do this by the old-fashioned raise your hand. Do you currently feel there's enough focus on the importance of gingival prevention? For those that say no, raise your hand. Okay, thank you. Who's saying yes? Good deal. I'm liking this. Okay, let's move on to my next question. Do you currently feel there's enough focus on the importance of gingival maintenance and management? For those that are saying no, raise your hands. Thank you. For those that are saying yes, raise your hands. You think there's enough focus on what we're doing? Thank you. Okay. So what I'm going to do now is I'm going to introduce you to one of my colleagues, Professor Lisa Bono, Director of Idaho State University.
Thank you very much for the opportunity to be here today and to be able to present on behalf of Haleon, and I'm very excited to see the group that is here. And so, to get started, I wanted to bring up some numbers about the socioeconomic impact of oral disease. And this was a survey done by the Centers for Disease Control in 2022. And I wanted to go over the stats here and what these numbers mean. So, did you know that on average, 34 million school hours are lost each year due to dental emergencies? Over 45 billion hours are lost in workplace productivity for adults due to dental disease. In 2017, there were 2.1 million emergency room visits for untreated caries, periodontal disease. In 1996 through 2013, 25.5% billion was spent on dental care for children and adolescents. And we know that 18% of working age adults report that the appearance of their oral cavity, their teeth, actually hinders their ability to interview and apply for jobs. And this increases to 29% for persons with low incomes. And we have 1 in 6 children that have experienced some type of caries in their life. 1/2 of adolescents aged 12 through 19 have had caries, and 1 in 6 still have untreated caries, which really speaks to the access of care issues that we have. And we know that oral disease is largely preventable, but yet we still have these statistics that are occurring. 1 in 6 adults age 65 or older have lost all their teeth. 1 in 4 adults have age 30 or older show signs of periodontal disease. And then we know that people who smoke are 3 times as likely as non-smokers to lose all of their teeth. So this really ties into oral health related quality of life. And what is that? This is a conceptual model that we use when we have patients in our operatory. We teach this to our students if we're educators. But we're looking at the whole person's health and what their quality of life is related to that. And so we look at their oral health or their disease status, and this can involve health, gingivitis, periodontitis, are they in pain? Then we look at their functional status. Do they have the ability to chew? Can they speak? Can they swallow? And then what is their emotional status? Because they are in a disease state. So are they anxious? Are they feeling depressed? Are they stressed? Or if they have good oral health related quality of life, are they happy? Do they have a good self-image? Do they feel attractive? And then we look at treatment expectations. And remember, we want to customize this for our clients, our patients. And are they satisfied with the treatment outcomes, or are they not satisfied? And why were they not? What can we do to help them? And then we're looking at their general overall quality of life. And with that, we're looking at their environment. Are they able to get a job? What is their socioeconomic status? Do they have access to oral health care and general health care? And then what is their sense of self? Do they have self-confidence, or do they not have any self-confidence because of the disease burden that they're experiencing? And so we can see that because we have these oral health related quality of life issues, that there are oral health policies that have been developed. And there are many, many institutions out there that have developed these policies. And I'm just pulling up Healthy People 2030. But they have the goal of decreasing dental decay in children, adolescents, and adults, including our older populations, increasing early detection of oral and pharyngeal cancers. And if you've been here at this meeting, there was a great presentation yesterday on the early detection of oral pharyngeal cancer and how important that is. Increasing access to oral health care and use of our oral health systems that we have in place to help people, and increasing access to dental insurance, because we know not everyone has that supplemental insurance. The ADHA, our own professional association, wants to put forth policies that address and advocate for evidence-based oral health management and strategies for the prevention of oral health and systemic diseases. And we also want to look at the availability and accessibility of quality, cost-effective oral health care. So what does this mean when we look at our current dental codes or billing systems? And what I find really interesting here is if you look at this slide, we have health and gingivitis lumped together on the D1110 code. And just a question, food for thought, as you're sitting here today to kind of take away and think about that, should we really have a different code for gingivitis? It shouldn't be lumped in with health, right? Right, it's a disease process that's already occurring. And so it's really important to look at this and not let insurance dictate our care to our clients and to customize those treatment plans and to get patient buy-in. And Crystal's going to be talking a little bit more about that, how we do that through motivational interviewing. And we may need to tell our patients that they may need to come in more than every 3 months. They may need to come in every 2 months. They might need to come in every month, especially if they have a high caries rate, or they have they're immunocompromised. Their immune system's not it's not functioning, and they're not able to fight off that bacterial load. So I just want to take a quick path down memory lane. For many of you that are just out of school, this will be a really quick review. But we're going to talk about biofilm development. It all begins with a biofilm. Now, biofilms are everywhere. They're out in our environment. They're on our bodies. Anywhere there's a moisture available, there's a biofilm. So if you've been out hiking or camping and you picked up a rock in the stream and it was slimy, that is a biofilm. Biofilms are made up of many, many different types of bacteria. And in the oral cavity, there is over 700 different species of bacteria that reside there, and they all have unique roles. They interact with each other, and we know that some bacteria prefer an anaerobic environment, such as the one found in a periodontal pocket. We know that others favor oxygen, and so they like to be up above that periodontal pocket. And we know that this complex biofilm produces an extracellular matrix called EPS. It's a polymeric substance, and this functions like the glue. This is what holds that bacterial biofilm in place. So let's look at the acquired pellicle formation. This is the first step that occurs during the biofilm development, and it's full of salivary glycoproteins. It's a protein layer that's going to attract those bacteria, and they're going to be able to attach to those glycoproteins. And this creates adhesion for the pioneer bacteria. And so we know that there's a lot of gram-positive bacteria that will migrate to this. It occurs on a clean tooth surface, and it occurs within seconds to minutes. And it starts to create that home environment. So I like to do a little analogy with this. I relate it to a family unit. And so family units can be partners, they can be boyfriends, girlfriends, they can be the traditional husband, wife. But they're looking for their starter home, and they're able to get their first starter home, and it's nice and clean, and then they start to build that family unit, and there's more and more. So maybe pets join our home. We have children join our homes, and they grow up. And so we start to see this process where the bacteria are coming in and they're aggregating. Not that we're compared to bacteria, by the way. Just want to add that disclaimer in, but some comments up here on the front row that maybe it is with kids, but so we see this secretion of the EPS, and we see the migration of gram-positive rods and cocci to this area. And so these early colonizers come in, and they start to set up so that other bacteria can come in and attach to these pioneering bacteria, and they start to create a space for that to happen. So now we go into the biofilm growth. So this is when our families are growing, our pets are growing. And we all know with children, they have friends. And when they turn into teenagers, there's more friends. And they start to camp out at your house. And so one of the things that happens here is there starts to be these nutrient channels that are going all throughout the biofilm with water and nutrients. And if any of us have had teenagers and we're feeding all their friends and they're playing sports, those nutrient channels can get depleted pretty fast. It's a lot of shopping, and I used to love getting up in the morning and I'd see a note on the fridge. I'd just gone to Costco, bought the 5 dozen eggs, loaves of bread, 5 loaves of bread, 2 gallons of milk, and there'd be a note on the fridge. Mrs. Bono, we're out of bread, eggs, and milk. You might need to pick some up next time you're at the store. So we have these nutrient channels that are feeding the bacteria. And then what we see happen here, so we have more negative anaerobic bacteria coming in, but they establish cell-to-cell communication, which is called quorum sensing. Now, teenagers have quorum sensing down to a T. So sometimes these cells respond to only a couple signals, or they can respond to a lot of signals. And so I equate the couple signals as when you have and this happens to you as a parent, at some point you become dumb and stupid and you don't know anything. These are the cells that respond to just a couple signals. So you're trying to communicate with them and you get the eye roll, or you get this look like, what could you possibly know what's going on in my life? You've never had this experience. You've never done things like this. And then they go over and they get with their friends, other teenagers, and all of a sudden this quorum sensing explodes. They are communicating on all levels. They're planning a prank on a friend. They're planning a party. And you see that multiple process occurring with multiple ways to communicate. And by the way, bacteria have evolved their communication process far more than we have as human beings. And so there's going to be more research out there really discovering new ways that they are communicating. Now, part of the quorum sensing is it starts to regulate the growth of the bacteria. And then it starts to signal them that they need to leave. These nutrient channels are starting to run out. And I call this the empty nester syndrome. So how many in here are empty nesters? Great. How long did it last? I got 2 years. And because of our economy, the recession, and the price of housing, my daughter was in tears and she had to move back home. She didn't want to. I have a son and daughter-in-law who were also in tears and didn't want to move back home, but they wanted to make sure they had a space if they had to because their housing is so high and they're trying to get through school and cost of living and food. And so it looks a little bit different than these bacterial colonies now. But back at the time when I left home, we left. We didn't ever return. We went out and colonized our own little home and started our own families. And so what happens in this process is you see these bacteria leave as single cells. So like one child going off to college, or they leave in groups, they leave with their friends and all go to college. And we really see a proliferation of the negative bacteria at this time. And now we have gingivitis, which is clinically evident at 10 to 21 days. That's always a board question. So let's talk a minute for periodontal disease. We know it's comprised of gingivitis and periodontitis. Gingivitis, we know, is confined to just the gingival tissues. There is no apical migration of the junctional epithelium. It can occur on a reduced periodontium, but it will still be that gingival inflammation. It does not go down into the underlying bone structures, and it is reversible. So very, very important that we educate patients early on about this process because it can be reversed. There's 2 types. There's plaque-induced and there's non-plaque-induced. Under plaque-induced, we know there's also multiple causes that contribute to this bacterial formation. It can be defective restoration in the oral cavity. You can have hormones that contribute to this. Medications, we know, can contribute to the gingival inflammation. And then we have the non-plaque-induced. And the non-plaque-induced involves genetic or developmental things that occur. And we know that these different things can affect the gingival health of persons. And Kristen's going to talk more about these different types of processes. So let's go to the periodontitis. Periodontitis involves the periodontium. It's irreversible. There's apical migration of the junctional epithelium. It extends now into the connective tissue, and now we have bone loss. We know that there are systemic disconnections with this process. Everything's linked in the body. And one of the things to find out with the gingival inflammation when we're educating our clients is that it may progress to periodontitis. It doesn't mean that it's always going to progress to periodontitis because we have those clients that come in with the inflamed tissues, there's bleeding, it's erythema, edema, and it just stays at that state. And that's because they have a good immune system that's able to fight that bacterial load, but many people don't. And then it leads into this periodontitis. So what can we do for periodontitis, gingivitis, and other things? There's many, many products out there on the market. And I just wanted to say really going back, P. gingivalis, which we see, gingivitis, periodontitis, there's new research out there showing that this bacteria now has the ability to evade our host, our immune system, so it can stay in the host longer. And it does that through gingipains. And so these bacteria are evolving. They're constantly evolving, and that disease process is present. So If we look at a systematic review of the literature, and if you look at this triangle, that is the highest evidence-based literature that we have found. So these authors looked at over 23 different studies, and they were looking at stannous fluoride. Now, we know stannous fluoride has been around since the 1950s. If any of you are in my age range, 60s, 70s, you probably remember standing outside in the hall and you got this little cup of stannous fluoride and you had to rinse with it, and it was metallic, didn't taste very good. Well, that is no longer the case. They have stabilized stannous fluoride now, so the taste is not an issue, and staining is not an issue. And so that's one of the things we may have hesitated to use this product before this type of fluoride because of the staining. But with the new products out there, they pair it up with SHMP, which is a sodium hexametaphosphate, and that actually prevents the staining and creates a nicer taste, so our clients are more, they adhere to their oral health regime, their oral home care. And so what they found when they were looking at these studies is it was originally used for caries reduction. And what they found, it has all these other effects on the oral cavity. And so in these 23 studies, there was a 17.2% average, the mean, reduction in gingival inflammation. And this ranged anywhere from 4% up to 35%. And then if they were using a toothpaste that had close to 0.5% of the stabilized stannous fluoride, there was a significant decrease in gingival inflammation, mean reduction. They had a 32.4% mean reduction in the bleeding sites. There was decreased biofilm formation. The bacteria were no longer able to, or the acquired pellicle, it created a slick surface, and so it was not able to adhere to that clean tooth surface, and decreased stain that I already talked about. And then they're also finding out that it had a significant decrease in the volatile sulfur compounds, which create halitosis in our clients, and calcium formation. So there was a reduction in calculus formation. So this is just a quick summary slide showing that the effects of stannous fluoride. So we inhibit that bacterial growth, we kill the bacteria, we loosen the integrity of that biofilm, and it reduces that carbohydrate metabolism that the bacteria need to survive. So where are Americans spending their money in healthcare as of 2020? So we know that over 200 million Americans are using mouthwashes of some type. We know that close to over 300 million Americans are using toothpaste products. Now, flossing, this one came from the CDC. We have a pretty even third split there. 30% report daily flossing, 37% report it less than daily, and then we have our 32% that never flosses. So we all have those clients in our chairs and on our clinic floors. And then toothbrushes. Over 130 million Americans in the United States are using the electric toothbrush, and over 260 million are using a manual toothbrush. So now I'm going to turn it over to Crystal, and she will talk more about the roles as a healthcare practitioner and how to create those behavioral changes in our clients through motivational interviewing.
Thanks, Lisa. So how do we play this role, right? Where do we come in? We know all this great information, and we know about gingivitis, and we know how to stop it. But of course, we knowing it is not enough. So imagine your patient walks in the operatory and they are sitting down with a preventive appointment, and they're asking you questions about your life. You're catching up with them, getting to know them. And then, of course, you lead to the ultimate question of, is there anything bothering you in your mouth? And they immediately say, yes, my gums are red and swollen and they're bleeding. And I mean, is this normal? Well, we know this is not normal, of course. But do those patients identify those symptoms to you just the first, time they walk in the door? Not always, right? Sometimes. Occasionally, they will tell you their symptoms. They might notice their symptoms, but they might be completely unaware. They might not even care that there's pink in the sink, and they might be unaware. So if it was this easy, right, we'd all have a much easier job if they were just self-identifying the early stages and symptoms of gingivitis. But we know it's not. We have a more active role. And where does that role start? So number one, of course, is assessment, right, our clinical assessment. And I would like you to just look at this slide and think about these different categories and these different areas that are on this slide. And think of your daily practice, think of your assessment routine, how you integrate assessment into your patient and client care, and think, does your assessment measure up? Assess your assessment. So think about all of these different things. Are you doing bleeding on probing and identifying that and accurately documenting it? Probe depths, gingival description, and a thorough one. Intraoral photographs, radiographs, patient risk factors. That's a lot. And this is only the first role, right? This is the clinical assessment. This is one of our major roles, but this is a lot to do. And so think, is every single one of these important? Do we have to do every single one of these each time? And you don't have to answer that. I want you to answer it for yourself, but just think about that and assess your assessment and think, what am I doing and how is that playing a role in my patient's gingival health? Because the role is more than just that, right? So we are addressing our clinical symptoms, clinical assessments, and we are looking at their personal, medical, and clinical at the same time. So it's not just enough to look at the clinical side. We're also looking at their personal motivating factors, asking them what they enjoy. What are their goals? What are their oral health goals? We're looking at their medical assessment. How does their health play a role in all of this? Do they understand that link between systemic diseases and oral diseases and the health of their mouth? And so we need to take all of this in as well. And this is just as big of a part of the assessment as it is the clinical aspect. So really, truly just looking at all of those and thinking, of course, this takes time, right? We know that. But looking and saying it's not just enough for us to be gathering clinical assessment about our patient either. When we're addressing these, we're looking for predisposing risk factors. And dental plaque biofilm retention does depend on some of these different factors. So subgingival restorations, for example, do your patients have those? Are we addressing those in our clinical assessment? Are we documenting those in the clinical assessment? What about overhangs, right? What if they came to you and they have had a poor history with their past dentist and they didn't have great restorations placed, or maybe the restorations have broken down over time and they are leading to more biofilm retention. Open contacts are going to impact food, and that obviously is a perfect environment and going to give plenty of nutrient channels to this terrible bacteria that lives there. And then, of course, oral dryness. So if they're experiencing these local predisposing risk factors, then that's going to put them at a greater risk. And this is leading to the biofilm retention. So I'd like you to look at this image. And speaking of those biofilm retention areas, I'd like you to look at the restorations that are present and look at the potential horizontal bone levels. Look at the restorations themselves. And look for any of those clinical assessment items, those risk factors that I just talked about. And let's see how many you can identify on your own, and then I'll go through what I see as well. She says between 4 and 5, there's an overhang. Yes, thank you. Anybody else want to be brave?
5 and 6, and open contact with bone loss.
5 and 6, open contact, yes.
There's bubbles in the composites.
Yeah, so there's space where it's, more radiographic or less opaque. Yeah, thank you, radiolucent. Yes, exactly. So we have food impaction potential. We have restorations, which are causing overhangs. Do you think that person is able to floss that area very effectively? Well, I can tell you they're not. I actually see a radiographic piece of calculus, right? So, so these are issues. And if they're not aware of these issues, if we're not charting them, removing the overhang or replacing the composite, then we could have a real, problem. If we're telling them to brush and floss and rinse, that's not going to be enough, right? We got to identify these. And the open contact, it looks like maybe there's a caries. I'm not going to diagnose, but maybe we can fix that too. All right, here's another one. So same thing. We're going to just look at restorations, look at bone levels, and see what we might see in this one.
Overhang on the distal 13.
Yes. That's quite a deep restoration, isn't it? Anybody else?
On like the luminaires, tight. Distal of 20 is not tight enough. Contact is not.
Yeah, the contour of that restoration is very poor. And so that shredding floss is impacting food, shredding food, and whatnot. And so again, these are going to lead to patients not being successful. And when patients want to be successful for the most part, right? And when we're leading them down a path that they can be successful and they have these different aspects that we're not addressing, then they're not going to feel very good about that.
Like, we like how. I mean, that's a conversation. They have to pull the dentist on the side first before you have this discussion with the patient. I mean, no one's driving the bus, right? I mean,
Absolutely. And these may, they may be restorations your dentist place, but things do happen also, right? There are pieces of composite that can break. I mean, it's not necessarily, yes, of course, you want to approach that tactfully and respectfully and never throw any previous dentist on the bus, but they do need to be addressed. That is definitely the important take-home message there. And then, as Lisa already mentioned, some of the different autoimmune diseases or systemic risk factors, we call these modifying risk factors. And so why do you think we call them modifying risk factors? Anybody want to be brave?
it's just changing your behavior.
Yes, so you can change some of these different things, but they call them specifically modifying factors because they don't cause disease. So it's modifying the disease that's already present. But that is a great point, because with some of these we will have to change behavior to be able to adjust these modifying behaviors, right? So smoking, there's metabolic issues that we can have, nutritional deficiencies, not getting the right nutritions, and then pharmacological agents. They might be on multiple medications. Obviously that influence their plaque and biofilm. And then also elevations in hormones or hematological conditions. So these are things that you may have to work with their doctor about and make sure that they're well managed, right? And some things they might be able to address, and something, they have to have a medication. They're not going to be able to be addressed in this manner. But if you have the totality of all of these different things, it's getting that big picture, right? So our second role. So we've come up with this beautiful treatment plan. We've assessed all of the different categories, and we have the perfect idea about what we would like to do, right? Of course, we can create perfect treatment plans. That's what we're the best at. But the question is your patient taking a role, a part of this treatment plan? Are they having a shared interest, a shared treatment plan, their own personal goals? Are they motivated? And if they're not, maybe why? But it's not enough for us, obviously, to just create this perfect treatment plan. It has to be phased out. They have to be on board. Lots of different decisions financially, time away from work. And so we have to make sure that it is something that they feel empowered to do, and they need to make a decision on whether or not they're willing to do that. And so, of course, we're going to lead the patient through our findings, lead them through the education, show them the images, ask them, do you feel like this is urgent? Do you feel like this is a disease that you would like to address, and hopefully that they say yes, right? Hopefully they want to take charge of their own lives and have ownership over that. But of course, determining their patient goals is very important at this stage. And that shared treatment plan should definitely include whether or not they're willing and able to have patient behavior change. And that's the most important component to my part of this presentation. Are they willing? Are they able? But if they're not willing, why is that? And when maybe meet them in a compromising situation. Yeah, you're going to be flexible and meet them where they're willing to meet you, instead of just holding them to a standard that they may tell you they're going to do, but it's really not going to happen. They're not going to carry these things out because they just want to please you at that point, right? But in understanding what they are willing to change and what that looks like for them at home. So they have to be realistic and they have to be achievable. And then, of course, the other shared treatment part of the plan is our side of that, right? Our preventive treatments and appropriate recare. And as Lisa already kind of pointed out, that appropriate recare should not be dictated by insurance companies. And we know that we have to talk to our patients about their ability to maybe pay out of pocket. And if they're not, what we can come up with. But setting that for them and telling them this is the recommendation by your oral health care professional. How can we make this happen for you? Because they might be willing to come in every 2 months, but they're never going to floss, or they're never going to use any product you're ever going to sell them. But you never know till you ask. So this is just an image about the role coming together, right? So we've got our clinical evidence. We've talked about what their findings are. They're on board. Everything's going to be great. They have confidence and whatnot. But does it always happen? Do we always hit the home run? Do we always have patients be compliant? Do we always fight gingivitis proactively? No, right? Because the plan has bumps. It doesn't always go accordingly. And although we have all the right components, there are factors to behavior change that we must realize should be present in order to be successful. So first and foremost, the patient has to believe they're at risk. How do we help them believe they're at risk? We use word for disease. You know, we have to tell them the disease progression process. We have to let them know gingivitis is a scary word. And when I first started, out of hygiene school, I kind of felt like I was reluctant to tell people, you have gingivitis, because it sounds threatening, and it should, right? It should be threatening. It is a threatening disease, right? So they don't have to believe they're at risk, and we need to help them with that. They need positive reinforcement. How are they going to get that? Well, you can't say, good job, you flossed tonight, right? You're not home with them. But you could have some potential follow-up, and I'm going to talk about that, about how we can follow up with our patients and try to keep them motivated. But also just telling them, you had 3 less bleeding sites this time. I mean, that's a win. Any progression, anything you can give them positively, or be able to show them if you have less, blood when you floss, and that's a success, and you need to take it as a success. And if you have more, just know that, it's a journey. Trust, motivation, these are all patient report things we're excellent at, right? This is like at the core of our hearts, being able to be communication with our patients and have those relationships. They need small changes, things that they're absolutely capable of. They need easy changes. So swapping out a dentifrice for a specialty toothpaste that addresses their gum health, right? Versus, I like the flavor of this other one, or I want whitening. Well, maybe use your whitening one time and your specialty toothpaste another time. What about a toothbrush? We just saw that dentifrice and toothbrushes were widely used, right? So not flossing necessarily, but then they could just have a more specialty toothbrush, finer bristles, get to their gums better, or electric, right? So we know all this. Capability, are they able to buy the products? Are they able to maintain the products? You give them 3 samples. I've had patients say, I just couldn't find those again. Amazon's helped, but we need to be able to let them know you can find it here, or, come back and get them or whatnot. So be able to have capability of these behavior changes. And they want to see outcomes. So, you can tell them all very long, but they do want to see a change. If you're going to suggest something and they want to get on board with it, the best way to do is tell them what they might expect if they're successful. And then patient goal ownership. So again, having them set their own goals, and this could be something very far from your goal, but that's okay. It's their mouth, and if they take ownership of it, they're going to be higher or more likely to be able to be successful. So if they have a failed goal, or if they're unwilling, you can look at the situation and ask them, why they thought that happened, or how they think they could be more successful. Maybe they just don't want to. Again, they don't like the flavor. There's always usually a bottom line of what changed, why the change didn't occur. And so you can talk about that with them at their recares. And that's another reason why frequent recares are so great. And then small achievable goals, behavior substitution, just like I was talking about. They're already doing something. Maybe they already floss, they're just not flossing properly. Or maybe they like to use a toothpick and they're just not using it properly. Or maybe they would use a toothpick over floss, right? All those easy substitutions versus just the routine of adding more to what they're doing. And so here's that follow-up I was talking about. So in this day and age, we have the ability to communicate with our patients outside of the dental office. And you do, of course, have to see if they'd be open to this and see if they're willing to communicate with you outside of, you don't want to harass them, but you could ask them, what is your preferred method of communication? Do you like to be text? Would you get on an artificial intelligence app and ask it questions? Would you be able to be emailed? Can I call you? Maybe we can Zoom and I can watch your brushing, or, anything like that. You can also have them bring their products in. But these days, there's a lot of opportunities to be able to follow up with your patients and address some of these things that I just talked about. Again, they have to be willing, but I think people would be, very appreciative of the time it takes. Now, you don't have to just do this either. Now, we're busy and we would love to, but you could have a team member support them in this manner, and you can get more people on board. And of course, if artificial intelligence is that capability, then they're going to be able to have that at their fingertips, and it's no work for us at all. We can just look at that information and check in as needed. So we can follow up, and that will increase our follow through. and behavior change for our patients is just so important. My final take-home message is I obviously am passionate about dental hygiene as a clinician, but what we do really ends when they leave the door, right? Like what we can physically change in them. So they are the most important part of this whole process, is what they're going to be able to do with their self-care. And so just helping motivate them and stay on board with their goals will definitely fight gingivitis and stop it in its tracks.
Thank you, Liesl, Crystal. Amazing information, right? I mean, this is all something that we need. It's something that we need to re-engage our brains with and really try and get back to our roots of understanding what the underlying condition is all about. Gingivitis, as I said from the very beginning, is a disease. After all, the end of the word, iridis, is disease. That's what it is. So yeah, we need to talk to our patients, and we need to talk to everyone and get them to understand this is reversible. We don't have to do this, and we don't have to live with any kind of blood coming out of our mouths, because that's not right. And it doesn't look good. It doesn't feel good, and they don't know that, because of course we all know that doesn't hurt them. So let's talk about how we become the champion preventions and management of gingivitis with a specialty toothpaste. So we go back to having 4 questions to ponder. All right? It's very important that we talk to our people, find out what percentage of the people in your area actually see a dental professional. Because you'd be surprised how few people are really going at the dental offices. All right? The other thing is, are they going routinely? Crystal talked about the potential of having them come in more often. When I was practicing, I had patients that would come in once a month. They didn't care that they had to pay out of pocket. All right? We can't have the insurance companies dictating what health is. That's the patient's understanding, and for us to help them understand that. All right? And we need to be able to, as I said in the very beginning, scream this loud so that everyone understands that. Where are these people getting their information from? We've got to make sure that it's accurate, right? Google is an unbelievable thing. I literally just had surgery 2 months ago, and one of the things that I was doing in post-op, believe it or not, post-op, I had my phone, and I'm Googling what's going on with me. I ended up having a reaction to the anesthesia. I'm fine, obviously I'm good, but I had my physician going crazy. He's like, I'm taking your phone away like you're a child. He said, enough. And that's what our patients are doing. They're looking at things, they're not really getting the right information. I mean, let's face it, Wikipedia is out there, but you can flip it around and change things up. We want them to get the accurate information so that they understand this is important, that they need to be able to resolve this. All right? Here's a very important question. Why are early stages of gingivitis not seen as an urgent condition? This is so critical in getting people to understand that if we recommend a specific toothpaste, a specialty toothpaste, if we recommend a particular protocol, all right? And like Crystal said, it has to be a progression of how they're going to engage their protocol. We can't just throw the kitchen sink at them and say, do it. Because I had an inorganic chemistry instructor that I will never forget as long as I live. He said that people suffer from what's known as the omega syndrome. You all know what the omega symbol looks like? It's an upside down U, right? Well, so here, it starts here, it goes here, and it goes out. It never goes inside, hence the omega syndrome. Okay? We need people to understand that gingivitis can be reversed. And unless they start hearing and not suffering from the omega syndrome, they're not going to get it. You had a question. As a dental hygienist, we say, you have gum disease, but then the dentist will come in and say, everything was great, right? Anyway, that just covers that was what here, no pun intended. But yes, that is the problem, all right? But I grew up as well. It was, you have no cavity, so everything's wonderful. Yet, how many kids, unfortunately, do we see with gum problems, all right? How do we get them to start understanding that the oral care that they learn about when they're younger actually takes them through their life, okay? So it's very important, and thank you, that was a perfect asset to my conversation, all right? Because we need to ask ourselves, along with the patients, why are you not treating this, okay? How many people just treat your patient, you say, yeah, you've got some bleeding sites, and they go off for 6 months. Or maybe you can get them in 3 months. And then, like you so eloquently put, the dentist says, oh, you're fine, okay? No, you're not fine. You have bleeding areas. You don't have pocketing, but the potential is you're going to. And we can reverse it now, and we can help you do that. But we need you to be on board. We need you to buy into this. And so those are the kind of things that we need to get everybody to understand, because we don't want to have to submit them to going to periodontist. We should be able to cure this within a relatively unique time. And that time is up to our patients. And we need to be able to communicate with them and follow up, as Crystal so nicely put, and shared all kinds of different things with you. Illustrate generally has a desire to work with all the professionals in improving health, because it's a mutual beneficial appointment for both of us. What helps us helps our patients, which helps you. All right? So it's a global effect that we want to make sure that we get to, so that we're hitting all the targets and we're getting to everybody. You know, there's probably like, I believe, 120 people here. So if you all told 5 people, and then they told 5 people, all right, it spreads out. We need to be able to get more and more dental professionals on board with understanding gingivitis and capturing that in our lifetime, because it really can help. Gums matter. And some ideas, and I welcome your thoughts, but we can use infographics. We can link to various websites, making sure that they're accurate websites. Training, all right? When was the last time that you went to a school and talked to students? When was the last time you went to a women's group or a men's group and talked to people about gum health or any kind of dental health? It's really important that we spread the word. We have the knowledge. We are the champions. I need you to be the cheerleaders, to be able to get out there and show them that gingivitis can be reversed. All right? So, what are your referral criteria? When you go to assess your stuff in your offices, why are they referring gingivitis patients out? Why aren't you treating them yourselves? All right? Where are you raising the awareness? All right? As one of the things that Crystal talked about was, we have one code, one insurance code for general dental health. How do you have a good, healthy person, all right, that really does have good hygiene, have the same insurance code as somebody with gingivitis? Doesn't make any sense to me. Does it? So I want you all to start raising that flag and telling people, telling politicians, telling policymakers, it's got to change. We need to be able to reinvent this, and we have the power to do it. Again, having the voice is one thing. Having a loud voice is something totally different. So, let me ask you a question. Do you think this discussion has provoked the need to radically rethink how to prevent and manage gingivitis? Raise your hand if you think the answer is yes. Anybody don't? Anybody say no? Thank you. No, not done. But yeah, this is so important. I really can't emphasize it enough that we have that loud voice, and we need to be able to get to everyone to get them to understand prevention and management of gingivitis is key to success. Because having bleeding gums is not cool. I don't care what anybody says, but there's 1 in 3 people out there that suffer from some form of gingival bleeding. That's just not good. That's way too many people in this world, all right? And 75% of them are not even acting. So we need to be able to talk to people around, write articles, I can't emphasize enough that you have a community that you live in. Get out there and talk to people. It's so, so important. So did you know that there's a toothpaste and mouthwash that is engineered specifically to help patients with gum health problems? Because there are specialty toothpaste. It's not just everyday toothpaste. I need you to start recommending information for the patient, which not only includes a toothbrush or dental floss or interdental brushes or things like that. It's actually the medicament that they're using needs to be tailored for their needs. And you all have that power to get them to understand that, because your recommendation is so important. People take what you say as hygienists, as the gold standard of moving things forward. So it's really important that we get people to understand, and as our marketing people have said, pink in the sink is not cool. Using a toothpaste that helps prevent gum bleeding, or bleeding gums rather, is important. We have a clinically proven toothpaste to help enhance plaque control when it's used as directed. It's specially formulated for people that are spitting blood in their sink. It is called Parodontax, and it is made by Haleon, the experts in gum health. And I am very proud to say that I'm part of the Haleon family, as my little disclaimer. Okay? So Parodontax brands has always been focusing on providing oral health solutions to improve gum health. At Haleon, we have a humongous team of professionals that are experts in formulation, in analytical testing, and they're not just scientists. There's actually dentists and hygienists on these teams as well. And we perform clinical testing and studies to help improve oral health. And that's why it's so important, because we need to understand that when it's a clinically proven product, it's something that you can feel comfortable recommending. So getting back to the beginning, now is the time for you to take gingivitis seriously. So what are you going to do differently? That's what I need to ask you. And that's what I need you to think about when you leave and you go back to offices next week. It's so, so important to reach the masses. And I want to thank you for your time. I want to encourage you to go visit our representatives and talk to you more about Parodontax at booth 203. And also go visit our website where you can get more continuing education, and you can learn more about the clinical studies that we have on the site for you. So don't just take my word, read the science. It's so, so important.
So thank you.